Hi, I'm Andrew Guyman. I'm a fourth year medical student at the University of South Dakota Sanford School of Medicine. Today we'll continue our Anesthesiology 101 course on day 10, discussing analgesia, opioids, and multimodal pain control. Our learning objectives will include discussing opioids, acetaminophen, NSAIDs, gabapentinoids, ketamine, muscle relaxants, Prestex, and local anesthetics, and the receptors that they affect, and then some of the unique aspects of each of these medications. And then we'll also discuss using ketamine for refractory pain, how to decide between using different sorts of opioids, and differentiating tachypnea when it could be caused by pain or various other things. The first class of medications that we'll discuss are opioids. So opioids primarily exert their analgesia effects on the mu receptor. However, the kappa and delta receptor also have some analgesia effects as well. The mu receptor is responsible also for the major adverse side effect of opioids that can be life-threatening, which is respiratory depression. So opioids exert their effects on two different areas within the body. Here's our guy. We're talking primarily about the mu receptor. So they affect the mu receptors that are in the spinal cord, and this attenuates the pain response. So if there's a pain response from the leg that goes up, because it attenuates the pain response in the spinal cord, it reduces the amount of pain that is then sent up into the brain. And then it also functions within the brain and reduces the perception of pain that the brain feels itself. So it affects the mu receptors in both the brain and the spinal cord. It has another useful effect, which is going to be reduction of the cough reflex. This is useful in anesthesia during endotracheal tube placement or removal. And then, like I said, the major adverse side effect of opioids is respiratory depression, which can be life-threatening. Our next medication to discuss is acetaminophen. So the mechanism of action of acetaminophen is actually unclear despite how common it is. It's thought to inhibit cyclooxygenase centrally, but not peripherally. So that's why you don't see the same like anti-fever effects that NSAIDs cause, because it doesn't inhibit cyclooxygenase peripherally. However, this is still pretty unclear. Some of the unique aspects of acetaminophen are it's dosed the same orally and IV, never exceed 4 grams per day. And then this is reduced to don't exceed 2 grams per day in a patient who has chronic alcohol use because of the anticipated hepatic dysfunction. And then it also, because it is eliminated by the liver, can potentiate the effects of warfarin. Our next class of medications to discuss are the NSAIDs. So NSAIDs are cyclooxygenase inhibitors. They can have some major side effects. So adverse effects include causing renal failure, GI bleeding, and then there's some evidence that shows that they can cause cardiovascular disease. However, of course, this is going to be specific to the NSAID. For example, aspirin is used super frequently to treat cardiovascular disease. So this one is a little bit more wishy-washy depending on which NSAID you're using. They provide dose-dependent pain relief. So generally, you'll want to start at the lowest possible dose and then escalate up until you're sufficiently managing their pain, or it would be unsafe to go any higher. And then Ketorolac is a very common NSAID that's used in the realm of anesthesia. You want to limit its use to 5 days, 5 consecutive days. And then, interestingly, the study guide, the workbook that we have, has a table in the back discussing NSAIDs. And it says that if you're ever going to use oral ketorolac, you'd first want to use IV ketorolac first before you transition to oral ketorolac. The next class we'll discuss are gabapentinoids. So don't be fooled, they start with GABA, but they don't affect the GABA receptor. They antagonize voltage-gated calcium channels. They were once used very heavily in multimodal analgesia, but that's now been challenged. Dr. Toom at Sanford, he's pretty strongly opposed to using gabapentinoids, at least universally, in multimodal pain control. His thought was in the studies when they showed that they had benefits in preventing pain, you might have just been seeing the effects of some of the adverse effects of these drugs. So they can cause respiratory depression, and this is a synergistic effect when used in combination with opioids. They can cause dizziness and drowsiness, and then water retention as well. But Dr. Toom's thought is maybe you saw less respondents reporting pain when they were on gabapentinoids when they studied this for multimodal analgesia because they were just drowsy or too snowed to even report that they were feeling pain. Ketamine is a NMDA antagonist in both the spinal cord and brain. One of the very beneficial effects of ketamine is it does not compromise the airway. And then some of the major side effects of ketamine include hallucinations or vivid dreams, a feeling of dysphoria, which is going to be the opposite of euphoria, so just feeling uncomfortable, and then excessive salivation, which that's important if you're trying to intubate a patient and then they have excess secretions in their mouth. The hallucinations can be mitigated by administering a benzodiazepine like midazolam beforehand. So muscle relaxants are going to include cyclobenzaprine. This is otherwise known as Flexeril. I guess it is used in some multimodal management systems. Personally, on my rotations, I haven't seen it used very frequently. Its mechanism of action is going to be a 5-HT2 antagonist. This is a serotonin receptor. And then most of the evidence for reducing pain comes from reducing like back pain or like muscle pain. Dexmedetomidine, otherwise known as Precedex, because this can be super tricky to say, is a alpha 2 agonist. Also, like clonidine. Clonidine is a blood pressure medication. So I was curious why dexmedetomidine is used as like a analgesia agent or sedative, while clonidine is used for blood pressure. The big difference that I found is Precedex is 8 times more specific for the alpha 2 receptor, whereas clonidine is less specific for that receptor. kind of the claim to fame, or one of the cool aspects of Prestex is it causes what's called a cooperative sedation, where a patient can have a smooth transition between wakefulness and a sleep-like state just with gentle stimulation. I've heard nurses describe it as causing patients to have better manners. It causes minimal respiratory depression, which is another large benefit. Uh, Unfortunately, it has a very variable, context sensitive half-time. So the longer that you run it as an infusion, the longer the half-time of the medication. And then it can also be used as a adjuvant for local anesthetics. I've seen this called into question a little bit, but everybody is trying to find local anesthetics that last longer. And the idea is that if you mix Prestex with some of the local anesthetics, then that might cause the local anesthetics to last longer when you're providing regional anesthesia. Local anesthetics are a staple in multimodal pain control. So they function by blocking sodium flux through voltage gated sodium channels. They have a profound cause a profound loss of sensation and movement when administered regionally around a nerve. The big concern is local anesthetic systemic toxicity. Most commonly, this is caused if you accidentally inject a local anesthetic into some vascular source. But if you also inject too much local anesthetic into tissue, then that can be redistributed systemically, and then that can cause local anesthetic systemic toxicity. It causes central nervous system effects. So, like maybe some of the more classic ones would be perioral numbness or tingling or ringing in the ears, ultimately resulting in seizures, which can be very life-threatening. And then cardiovascular effects as well. You would treat last with an infusion of lipid emulsions to try to bind the local anesthetic that's intravascular. So ketamine is commonly used to treat refractory pain conditions. There's moderate quality evidence to support the use of ketamine to treat complex regional pain syndrome. And then there's controversial evidence to use ketamine to treat other refractory pain conditions such as fibromyalgia, headaches, and phantom limb syndrome. Despite the controversial evidence to treat these, it's still very commonly used. So this is just to provide a very broad overview of rational opioid use. So we'll discuss how you might view using fentanyl versus hydromorphone and methadone. So fentanyl has a very rapid onset of action of 3 to 5 minutes to reach maximal effect. It has a short duration of action when used as a bolus. The caveat to that is if you're ever infusing fentanyl, it has a very variable context sensitive half-time, which makes it last much longer if you're ever using it as an infusion. Now, if you're trying to decide between using these different medications, Example that the baby Miller provided is using an infusion of fentanyl when you want to take advantage of the longer context-sensitive half time. So if you're anticipating significant post-operative pain and you want to help manage that pain post-operatively, then you could use a fentanyl infusion. Something that's super useful with fentanyl is it can be administered via many different routes. So intravenously, intranasally, transdermally, transbucally are all different ways that you can deliver fentanyl. Hydromorphone can only be delivered orally. It has a longer onset of action of 15 minutes and then a longer duration for a bolus as well. And it could be used in an operating case in the operating room if you're expecting constant surgical stimulation or if you want to control pain post-operatively. So kind of in a similar manner is using a fentanyl infusion because you get that longer halftime with the infusion. Well, if you were just using a bolus, then you could do hydromorphone and then help manage the pain in the post-operative period. And then finally, methadone. So methadone has onset of 10 minutes. The Stanford CA1 manual actually advocated for using methadone more frequently than it is. It says that it's kind of looked over. It has the longest duration with a half-life of 1 day. So that said, according to the Stanford CA1 manual, they said you could use it intraoperatively to help manage post-operative pain if the patient is going to be monitored for at least 1 night in the hospital because it has such a long half-time. So the last idea that we're going to discuss is differentiating tachypnea due to pain, residual neuromuscular blockade, or the effect of volatile anesthetics. So the situation that our workbook presents is a patient who is about to be extubated, but they're tachypnic, and then you're wondering what's causing their tachypnea. If it's due to pain, you would expect there to also be hypertension or tachycardia associated with it because they are in pain. Now, that said, if there's a patient that has residual neuromuscular blockade, that's an uncomfortable feeling, so they also could have hypertension and tachycardia. So a big thing that you could use to differentiate these would be train of 4. And then if you were considering the effects of volatile anesthetics, you could look at the MAC that the patient is at or what the exhaled concentration of anesthetics is. I hope that this lecture helps you guys. Let me know if you have any questions. I'm sure that any of our attendings would be much more knowledgeable and also very willing to help.